Well, hello and welcome again to Medical Mastery, the podcast of the Emerald Coast Medical Association. I am your amaranthine host, Don Davis, MD, and I am very pleased to be here today with a friend, a surgeon, and I think our youngest board member now for the Emerald Coast Medical Association, Dr. Jamie O'Neill. Dr. O'Neill, thank you for being here today.
Good to be here. Thank you.
It is good to be here, okay? And you're going to prove that here by talking about everything that you know, okay? So
it's a very small repertoire of information.
Well, you know, Chris will fill in some of the gaps here, hopefully. That's what production does here. And by the way, shout out to Curiosity Marketing for making us sound smarter than we are here. So thank you, Chris. Jamie, welcome here. Welcome to Emerald Coast Medical Association, our podcast studios here, which should be familiar because this will also be our board meeting room. Spoiler alert. So why don't you start off by telling me where you're from?
Born and raised in South Louisiana, right outside of Baton Rouge. Mm-hmm. Spent most of my life there until after medical school. Went from LSU undergraduate medical school at LSU in New Orleans, and then we moved out from there. And after training, we did try to move back home for a couple years to work, and a less than ideal job situation. And then through some mutual acquaintances from Louisiana, found some people here and moved here.
All right. Well, look, this is great, but anytime I get a chance as being a fellow Louisiana person, I love to talk about it. So let's go back a little bit to a place that I called home for a while, which is LSU. There's a time and a place for everything, and it's called college. And you and 35,000 other friends, it's a good place to go. So tell me about what you majored in.
I did biochemistry with a chemistry minor was ultimately what I finished in. It was not what I started in. I kind of had a meandering path and thought I might at first do something in sciences. And after an undergrad job in a research lab, I realized I hated bench work.
It's totally different than the actual science that you learn about, right?
Totally different. It's a lot less exciting, a lot more.
Doing science is different than learning science. Yeah. And it's also kind of elucidating because, that whole process was similar to me. I had a biochemistry degree with chemistry minor and some other stuff. It's that, we kind of get this idea that science is just facts. And really, science is a deductive way of learning out whatever the truth is. That was kind of an interesting process to learn along the way, that you're not just learning disjoint facts, you're kind of learning how to think about things. So that's one of the things that I learned down at LSU. But there's also some other things to do at LSU.
Yes.
Did you find yourself... how do I put this? Distracted while you were there?
Just like most other people
at LSU, yes.
Big football scene, big party scene. So I had my share of fun, but I did finish college in 4 years. So
now you're just bragging. Okay, we get it, Mr. Latita. I found that pretty interesting relatively early in my career at LSU that. I would come home or come to the dorms or something like that after having been to class and realize that many of my friends had not gone to class or anything like that. And I was like, oh, okay, so maybe there's a little something different about how my thought process was about the whole thing.
You probably had the same thing in Louisiana, but they had the TOPS scholarship.
Yes, indeed.
So I had the TOPS scholarship, which was great because otherwise I was going to be paying for college. So
indeed, yes.
I always had in the background a financial incentive as well because I knew I was going to do something more after college. And so in the back of my mind, I was trying to milk the most I could out of the top scholarship, hence 4 years and such. But I had my share of fun during those times. It wasn't all books and whatnot.
No, it wasn't. Now, what did you think was insightful, or what did you learn from biochemistry that you think was kind of new and innovative at the time that maybe you didn't know going in?
That's a
huge broad subject,
topic. I don't truly know how I ended up falling in biochemistry at first. On the surface, I meandered. I knew it was in the sciences, kind of undecided. I looked at engineering for a while, and somehow I was like, I like biology, I like chemistry, and biochemistry was an amalgamation.
Be, right?
Yeah, so it just seems like great, and I really did love it. I thought it was great, like you're saying, knowledge. But when you try to apply that knowledge to ongoing research and discovery, it's a grueling process, and as I didn't enjoy the grueling process, but a lot of the traditional stuff you would learn in the sciences, scientific method, studying, researching, and then trying to apply it. It parallels to a lot of what's medicine now.
Yeah, I do think you can kind of extract some data points there that would lead to a future career in medicine, and not just from knowing the substrate of the amino acids or anything like that, but actually kind of learning how to think about things that I think would kind of promulgate itself in the future. I found that.
A lot of the actual content from biochemistry isn't very helpful in the day-to-day of my job, but the ideas, the overarching ideas. And I always had a medical background from that standpoint. I grew up in a small town. My grandfather was a family physician.
Oh, okay.
And
all right.
he graduated from LSU New Orleans in 1962.
Nice.
I was a few years later than that. But I was always at his clinic, which was very close to my growing up hometown. And so I just grew up around him, seeing that. And probably, family medicine is now different today than it was decades ago. And
yes. I mean, especially that small town family physician, because I mean, that's kind of a catch-all. You're going to be doing everything. You're going to be birthing babies. You're going to be taking care of sick kids, probably even home calls. I mean, it's.
I went on home calls with him whenever I was young. Just he took me along, and he stitched me up many times too.
Yes, so, exactly. Sometimes you get paid in like milk and eggs and other things like that.
He's got many stories about milk and eggs, and I think to this day, my grandmother's still alive, 90, but to this day, people still bring her produce from time to time and random game animals that.
Of course, yes, exactly, as South Louisianians do. So you went from there. Maybe you had your mind's eye on either maybe a scientific course or maybe even medicine kind of dripping there in the background. Take us from you doing, and I should say, I worked in a biochem lab too afterwards, so there's a lot of verisimilitude. I understand that concept of, this is not nearly as cut and dry as you would think it would be.
It's a lot more exciting on TV.
It is a lot, yes, exactly. Real science is not all that much fun. So you go from there and you decide to go into medical school. Tell me about that transition point or that thought process where you said like, no, I think I'm going to try this, because you're going to start going over a lot of hills and humps to do that.
Somewhere, I forget exactly when, end of second year of undergrad, third year, I realized that I wasn't going to be doing bench work, research for whatnot. And so I started looking at what I can do. And then that whole time frame, trying to keep school within 4 hours from scholarship perspective, 4 years from scholarship perspectives, it's like, what can I do? And so you change majors, you lose a bunch of credit. And I knew I was always going to do something more grad school wise, or assumed I would. And medicine being a familiar background, I was always peripherally interested in it. And so I started looking more in that route. And so at some point around then, I was like, I'm going to go this pathway. And so you still was able to maintain a biochemistry major, and then minor in chemistry wasn't a far stretch from that standpoint. And so I tailored it to that direction. And
once you start down that pathway, then this is what I kind of think of as the cursus honorum in terms of how you're going to go through life from there, because it's not really handed in front of you how you apply for medical school. I mean, you have to start looking it up and you have to research, and there's nothing that's fed to you. You have to go, I've got to go get this record or go take this test. I mean, to this day, I don't even know how I figured out how to take the MCAT. I mean, there's information available, of course, but you have to start looking this stuff up, and you have to start moving towards it. And you've got to start saying, geez, while you guys are doing this thing over here that might be fun, I'm going to be kind of pursuing this other thing.
And hindsight now, it's not really a regret per se, but knowing that I went to medical school, I wish I would have done a different major that would have been more useful.
Yes, exactly.
Whether it's a language
Taking
or business
history or
history,
yes, exactly.
Art, just something, but it, like I said, it's not really a regret, but I really did enjoy college and knowing I went to medical school. But at that point, you switch, and then it's like, you're going to add an extra year. It's like, well, I'm not doing that.
No, I know better than that. Two of my favorite courses undergrad were Shakespeare, which was fantastic, and then a history course that I had taken, which was really, really
one phenomenal. Of mine, I love to read too. That's something I really like. So one of my favorite
we're gonna
classes
get to that. Don't you
was,
worry.
world literature was one that I took that I really loved. And oddly enough, at the time when I was in undergrad, the Harry Potter novels were real big. They actually developed a course that was based on the Harry Potter novels. And so you read the whole series up until that time, which the last one wasn't out. But then you read all the
subtext and
yeah,
other
subtext
lore.
and
Yeah.
It was more of just by that point it was just an easy credit, but
I'm
it was
not even
entertaining
sure I got
too.
any extra credit for
Yeah.
doing the Shakespeare course, to be honest with you, but it was something that I wanted to do.
It's not
so.
as in depth as Shakespeare, but it was just one of
Perhaps.
those like.
I don't know. I think there is, but I also found some excuses during that time, like with some of the courses that I had taken to read things like Beowulf. Things that I would never just pick up on a whim and like, I guess I'll just pick up the Iliad and see what's going on there. No, you needed some kind of direction.
You read
so
it
like
and
that.
you talk about it and you have somebody to guide you. So
Yeah, thankfully, much smarter people than me that could guide me because I'm not sure I understand that now. So. But either way, so now you've made it into medical school. Did you cast a wide net, or did you say LSU New Orleans is probably where I want to stay? I want to stay a little bit close to home.
I looked around at other places, and still true to this day, school is expensive.
That's for true. Hashtag. Yeah.
And the top scholarship for undergrad, and so you look around, and it's like, ooh, I'm going to be in debt no matter where I go, but I can be in twice as much debt if I go to one of these private or out-of-state schools. Or I can look locally. LSU is a great school, especially for Louisiana residents.
Yeah.
And grandfather went there and whatnot. I knew other people from growing up that went there, and I've always loved LSU. And New Orleans is not a bad place to live for a period of time.
I had realized pretty quickly that I wasn't mature enough to live in New Orleans at that time. I eventually would, but med school was not a good time for me to be in New Orleans. I can say that. So
I applied, I think, in the end, I think I only applied to 3 schools, and it was the Louisiana ones. It was LSU Tulane and LSU Shreveport.
Yeah.
And I can't remember exactly the process. I think I might have gotten waitlisted for Shreveport, or I don't remember the time frame.
Mine was just the opposite. Yeah, exactly.
But as soon as I got that letter in, and I remember I was in the backyard of my parents' house. My mom walks around the corner with a letter, and it's a thick letter from LSU. It's not a thin 1-page letter, and I was like, oh, this is a good thing. And you open it up, and it's like, you've been accepted to LSU New Orleans. And so pretty much the same day I called and canceled all the other ones. I was like, accept.
Well, you could pay 2.5x that to go to Tulane, which was an option.
I never even heard back from them at that point.
Yes, exactly. It rendered that pointless. Well, I remember distinctly it was odd because, my acceptance letter was really the financial aid that had come. They did not send the formal letter. And so I called them and I'm like, you're saying financial aid. Does this mean that I'm in? And of course, all the...
Oh, we forgot that one.
Was that supposed to be to you? So I guess we've got to let them in now. Anyway, but that was a really thrilling moment. I mean, that was an unbelievable, just like, oh my goodness, this is incredible. I can't believe I did this. And it's almost quickly replaced with wait, am I going to do this now? This is going to be hard.
Getting back to like at the time in Baton Rouge at LSU, 4th year, final 2 semesters. I think I found out like right between or right around the end of the like the winter semester, whatever.
Yeah.
And so then they're like, oh, maintain a 3.0 GPA and all this stuff. And so the final semester of undergrad was really fun. And I skirted the edge.
We were biting nails there. Yeah, exactly. Hey, look, you got to get your yayas out there. Okay, so you did.
It was fun. We had a good time.
It's a good time indeed. So you get into medical school now, and the learning curve all of a sudden changes pretty dramatically. The courses in biochemistry I remember distinctly were, the 2 semesters and a summer semester in terms of lab and biochemistry. You learn that in about 6 weeks in medical school. It's coming at you rapid shot, and you kind of have to keep up with 100 or 150 of your smartest colleagues. It's a totally different experience when you're into it.
Yeah, you go from the pool of, like you said, 35,000 people, and granted, biochemistry is not an easy major, but even still, you're probably at the higher end of that range, and then you get to intern year of medical school, and you're not the big fish anymore.
Just going to class doesn't do it. You're going to have to be studying quite a bit with some pretty sharp people. Yeah. What did you like? Your first 2 years of medical school, and again, for the lay audience here, that is a very didactic time in our lives where you were kind of just being thrown a lot of stuff. You're not really learning all the things about being a doctor yet. You're really just kind of getting inculcated with as much knowledge as you can think of, and then some. The analogy is drinking from a fire hose. You just get as much as you can. What did you think of the first 2 years of medical school?
It's just grueling. It's hard. It's a hazing process almost to some extent.
Yeah, it's fair.
I would never want to go back through it.
No, surprised I did in the first place.
But I did it just like everybody else. I studied, obviously passed, made it through well enough. Biochemistry was not easy per se, but I was much, much more well adjusted to it, prepared compared to everybody else. So it's probably one of my easier courses, the 6 weeks or whatnot. The most difficult or challenging course at that time for me was the neurophysiology and pharmacology.
Yes.
Some of those things just didn't click right at first, and they got more in depth than we probably needed to for practicality. But
yeah, dorsal columns and other things like that, still to this day, it's fascinating physiology, and I don't know that there's an intuition that really guides me on it. Now, spoiler alert about where we're going to end up here, because this is going to be germane to your future vocation here. But did you like anatomy?
I did, but that's the first class you get to in medical school. And at LSU New Orleans, it was still live, or not live, but cadaver anatomy, like real.
Yes, exactly.
Real cadaver anatomy.
This wasn't vivisection, by the way. I just want to.
They've gone away from cadavers in a lot of medical schools, so it's.
I didn't even know that, to be honest with you. Okay.
I don't know how they do it, but
yeah.
So we did cadaver anatomy, and at first you're a little creeped out because you never do anything like that before.
Sure.
But I did like it. I didn't necessarily love it per se, but I enjoyed it. It was like, this is really cool. It's an honor to be able to do something like this, and I'm learning how to drink from a fire hose at that time, so it was a lot, but I enjoyed it.
It was I had some reverence going into this about you've got corpses, dead people who have died from some sort of medical illness, a room full of them, and they've decided to donate their body to science so that you can learn from them. That's an incredible thing for them to donate themselves so that you could hopefully gain some knowledge from this. And so I was reverent to that fact. And then you realize very quickly, once you kind of get over the initial hump of shock and dismay, and when you get into it and you're like, oh my God, this is fascinating. It was that kind of scientific brain that kicks in, and you get to see how the whole things work, and you get the questions from the anatomy professors that say, like, I'm a drop of blood, I'm over here, how do I get over here? And you're like, I have never thought about this as complexly as this here.
And the same thing with the room full of people. You get to see a bunch of different pathologies because all these people died from something, and so they have different diseases. But also your peers in the class as well. Some people are artists, and other people are butchers. And, and then they got most people in between there, and so you get different levels of skill with the dissections. So.
Yeah, and you're going to start to see, is this going to grade that out? Is this an eerie window into the future about what the careers are going to be like? Because you don't know at that time. So, it was the first time my particular cadaver had died of sepsis. And I had no idea what sepsis was. And so, this is the first time hearing this word. What is this? So
you start looking things up.
Yeah, and you have to start looking at a lot of things, a lot of terms that start to come to you very quickly. So you matriculate from there on to the latter years. Now, the third and the fourth year of medical school are a much more intensely clinical orientation. That's your first time where you're really getting into wards, where you're really getting into surgeries, where you're really going to start doing some stuff that is not really classroom based. It's kind of much more what we would be akin to what being a doctor is like. How'd you find those times?
My first rotation in third year was surgery. And I guess one thing that helped me is a lot of the times with all the difficult classes, challenges, whatnot, I just put my head down and went through it. It's like the only way out is through, kind of a thing. And
work harder, yeah.
I didn't really have a true pathway. I knew there were certain things I liked, certain things I didn't really enjoy, but I had no idea. Like I mentioned, my grandfather, if I would have been in the 60s graduating medical school, I very likely would have gone into family medicine.
Yeah.
It didn't hold an interest for me as I learned that year anymore. Just the field changed, just like a lot of our fields have. But I put my head down, did surgery, and I enjoyed it. It was a lot of work. It was busy, but exciting. And the rest of that third year, where you go through all the other different, I was like, oh, this is okay, but I don't really want to do this. This is okay, but I don't really want to do this. I definitely don't want to do this. So
I was going to say.
Got through the end of third year. I was like, oh, it's like I didn't realize how much I enjoyed that first rotation, because that was my first introduction. And so at the middle end of third year, I was like, well, I guess I'm going into surgery at that point. And then, fourth year, you tailor things around.
Yeah. So that's really interesting because you're kind of making a choice somewhere there in the third year. Do I really like the internal medicine side or the surgical side? Yes, there's neurology and there's psych and there's some other things that are kind of out there. OBGYN kind of fits somewhere in the middle of those kind of things. But that's really, you're categorizing yourself. Am I going to go surgery or medicine? And I found that the surgical rotation was probably the hardest I'd worked. Up until that point, by a bunch.
At the time, I didn't know I was working that hard because it was
First
my
rotation.
first rotation.
Yeah,
It was just a deer in headlights, just going through
5
it.
a.m. That's just what I'm going to do is get in here.
But yeah, it was at the end. It was the hardest rotation, but it was also the one that just touched me or spoke to me the most at that point.
Yeah. So, do you remember some of your early surgical operations that you were in, and kind of what that feel was like?
At the time, this was whenever I was in medical school. It was post Katrina, but it was a couple years. I started in 2007 and finished in 2011. And Charity wasn't around, but they in Baton Rouge, because LSU from New Orleans rotated in New Orleans, the outskirts of New Orleans, but then Baton Rouge and Lafayette. And so I went to all three of the cities. But at the time I did my surgery rotation, it was in Baton Rouge, and they still had the Earl K. Long Charity Hospital.
Yes,
and so I think that played a big part into what I liked because it was very resident driven, good, LSU residents. But I remember being in there several times. Just the residents were delivering it, and I'm not in this field per se anymore, but I remember doing a chest operation. It was just a lobectomy with the resident and the attending standing off to the side, and it's like, this is really cool. I have my hand in somebody's chest, and
yes.
And there's been other times in fields throughout there that was really exciting, but I don't know. I remember that one at Earl K. Long doing a lobectomy for stage 1, 2 lung cancer. I don't remember.
The Earl K. Long, you were going to get some pretty deep pathology. They were going to be untreated for a while by the time they came to you. But, those are some of the moments where you all of a sudden, I remember one of the early times that I had been with the cardiothoracic surgeon, and I was doing, that was my elective third year, was to do CT surgery. And that first time that you're doing bypass and you kind of take a step back and you're like, this is somebody's beating heart that's right here that we're going to bypass, and it's wow, this is incredible that we're doing this right here. And then, kind of getting to see the anatomy live and the physiology live, and it's a real moment of like you're standing on the shoulders of giants to get to this point.
And it's impressive just from the anesthesia side of it too, them putting to sleep and then all kinds of different circulatory arrest and whatnot, on purpose.
On purpose, yeah, exactly. This time, exactly. It's more knowledge than you can fully comprehend, and you kind of have to get comfortable with that. But at the same time, it's a lot of knowledge. But then you have to work too. You got to put in the hours. That's interesting. So you've decided surgery is going to be your thing. You're going to go do. You don't really want a life, so you're going to go into surgery. And
they don't tell you these things at the time.
No, they don't advertise it very much.
You're going to be busy, and it's like, yeah,
sure, I can do it. So, where do you go for general surgery residency?
I should mention too about this point. Where was it? It was somewhere right before third years. Whenever I met Jenny.
Yes.
Yeah. And
the future missus.
Yes. Which up until this point I hadn't really had a truly serious relationship. I had several, relationships, but nothing that progressed to that level.
Yeah.
And didn't know it at the time, obviously, but that was when I met Jenny. And at some point, into third year, beginning of fourth, things started to get more serious. Mm-hmm. But I forgot your original question. I just wanted to poke into that.
No, that's great. Well,
she played into a lot of these decisions honestly, after the fact.
This is amazing just because, it's hard to be a human being during that time. Mm-hmm. It's really hard to be a human being when you're in residency.
Can't believe she put up with some of the stuff I had to do at the time.
And sure, you've got some good prospects, but like you're signing up for, this is going to be 6 to 10 years of somebody that's just, they're working really, really hard and doing a lot of stuff. That's not to say that we're the only field that does that, but this is a pretty intense thing to sign up for. So good on her.
Well, good on her. I don't know. Maybe she was foolish at the time, but I'm glad she stuck it out.
Maybe she's foolish now. Either way, the point is. But you still decided to do general surgery residency. So,
like I said, at some point during third year, I realized I wouldn't be truly satisfied doing something else per se. And with surgeries, at that time, you go into general. I know you can do some specific targeted surgeries, but you can go into general and you can pretty much go into most surgical fields from that with additional training. And so I kind of figured out what I was going to do. Mm-hmm. And so I started going that pathway in fourth year. And I forget the exact time frame of Jenny and I's relationship, but at some point during that early, middle, fourth year, it's like, all right, we're probably early fourth year. It's like, we're getting serious, and there's going to come a point at the end of fourth year where I'm moving, I'm leaving. I don't know where I'm going.
Yeah.
I don't truly know how long it's going to be for, but it's going to be for general surgery residency is 5 years. So I was like, it's going to be a minimum 5 years. Hope it's no longer than 7, but we'll see. We'll see what happens. And but I'm moving. It's going to be hard. There's going to be a lot of things over the course, especially more early on, that are going to suck. But it's like, not saying we need to break up or anything, but just understand what you're getting yourself into. It's like, I'm fine. We can move this relationship forward. But this is going to be tough for a little while. And she was a trooper. I mean, she had no hesitation.
I actually think that that's remarkably mature of you, because, you don't want this to be transactional, but you also want to say, like, look, we're about to get into a weird place that we would love it to be island hopping around and Jeff pining around the world, but you may not have that option for a little while until we get to something else. So good on you. But either way, she decided.
And she'd never moved out of Louisiana at that point. I'd never had either, but she always thought she would be a hometown kind of girl. She was in occupational therapy school at LSU. That's how we ended up meeting, through friends of friends. And whenever I was like, we're going to move away and from all your family, and it's just going to be us, and a lot of the times it's just going to be you.
Yes, exactly.
And so she didn't even hesitate, and here we are, 15 years
good
this year.
Good on you. Yeah, good on you. All right, so you're going to do surgery residency now. Where did you end up going for?
I didn't have a direct pathway. I ended up doing a preliminary year at MUSC in Charleston.
Yes, okay.
Loved MUSC.
Beautiful facilities there, lovely area, really awesome place. Yeah,
loved
good
it.
program too.
And somewhere during that time frame, had to reapply for surgery and whatnot. And I loved Charleston, loved MUSC, but I started looking at some other places too. And Charleston was a little bit too much pretentious, or
very
nice.
It's like a high class New Orleans.
And from a surgery resident perspective, you work very hard, but they expected shirt and tie every day to work, and outside of the operating room, the only place you could wear scrubs was in the operating room. And I had like a 10-block walk from the parking lot. There's just a lot of things about MUSC that is like, this is great. I'm learning a lot, but it's a lot of things that are not my personality. I'd rather be in flip-flops and a t-shirt kind of thing. And ended up going to ETSU, East Tennessee State University.
Okay. All right.
And I remember on the interview over there, it was a good group of guys. They worked their tails off, but at the same time, they're like, we prioritize family. Because you go to some of these interviews, and they're literally at that time advertising their divorce rates. And well, this is
the badge of honor.
Yeah, it's like, I'm just married. It's like, I like her. I don't know why. I don't know why we're talking about this, but I kind of X those out. And I remember going to that place. It's like, you're going to work hard, you're going to work a lot, but we're going to prioritize family. You're going to try and get some time off, and yada yada yada. And then you see all the residents over there. It's like, it's a hidden gem. And one thing I was interested in at that time was the bread and butter general surgery. It's a lot of places you go, they have, especially the bigger centers, they're specialized and more nuanced areas. And I loved it. I ended up going to ETSU in Johnson City, Tennessee, Northeast Tennessee. Spent 5 years there, and we strongly contemplating staying up there.
Yeah. But, it tends to be how it is. You tend to fall kind of close to where your residency program is. I think there's a lot to be said about that. I think there's this vestigial tale that surgery drags with it almost more than any other medical specialty, in that the pride and honor of you working more than anybody else, or that kind of like, this is the hardest thing in the world, and I'm still going to take on more, and I'm going to smile through it. And I don't ever see my family or my kids, but that's awesome. This carries on from the 30s and beyond.
Some of the things they were bragging about just weren't congruent with me and my personality, and that's why whenever I was at ETSU, I was like, we're still going to work hard, but we're not trying to.
Of course, I'm here to learn, but ultimately,
I want to be a person at the end of this.
Exactly. I don't want to lose sight of that, and that's good on you for having that insight. So now, you've finished your transitional year. You're on to your second year of residency, but your first year of actually being, in surgery residence. tell me what that's like. Are you starting to do your own surgeries without attendings in the room? And
Well,
stuff?
they were not necessarily out of the room per se, but it was a lot more hands-on, a lot more
Yeah.
senior resident guided than
Yes,
previously.
yeah.
And I forget the time frame, but the early 2000s legal such and such came about to where some of the glory days of surgeons and surgery residents training without attendings in the room, it's still pockets around, but it was less and less just from so there had to be more supervision.
Still, you are getting your hands dirty,
Yes,
quite
definitely,
literally,
definitely.
and getting in there and kind of learning on the fly and realizing that,
More so at ETSU than MUSC. You were in the operating room from day one onwards.
and you're learning, at the same time while you have to learn this skill because, as Chris Johnson has pointed out, you only have 5 years to learn this. So
It's a whole new drinking from a fire hose at that point.
it's a whole new in terms of just learning how to be a surgeon, but you're also learning the art of medicine at the same time, which is, again, different muscles to flex of, learning not just how to remove a gallbladder, but when to remove the gallbladder and how to take care of it afterwards.
The easy part is the surgery. It's knowing when not to operate and what to do afterwards and who's a candidate for what not. But it's...
Boy, and that takes a lot of time, honestly. It takes time after you've finished in order to really get to this is the right thing to not do anything about.
It took several years to get to that lesson. The first thing, you're just trying to figure out how to operate, and you don't worry about when not to. You're just so eager and hungry to get in there and do it and do it and do it and do it. And at some point in the latter years, they try and drill some of that more into you. You start to realize it yourself as well. It's like, we don't need to operate on every person.
Yeah, I remember during med school, my surgery rotation, the fifth year senior residents, they seemed like they could do anything. I mean, they were just so confident about anything that they were doing, but rightfully so. And I mean, they didn't seem to get into too much trouble, and I didn't realize until much later that they were probably scared too. I mean, so now, did you decide to do anything else after you had finished your residency at ETSU?
That was another conversation with my wife, but yes, I did. I'd already.
Hey, you know how we've been doing this for 6 years. What if?
What if? And so I looked at different fellowships, and I really love general surgery.
Yeah.
Bread and butter general surgery is fun. If you you start looking at lifestyle too. You see the lifestyle of the people who are your mentors, and where you work, what kind of you want to do. As a general surgeon, if you go to a bigger city, you're going to have to find a niche almost.
You've got to be able to bring something to the table.
Got to be able to bring something to the table. So then a lot of people specialize, and whatnot. We always wanted to come back home to Louisiana. Was what we thought was going to be a good thing. But I liked a lot of different fields. I really did I wasn't a big cardiac interest, but I loved the thoracic surgery. Cancer's never been a big interest of mine, but obviously it's part of what we do. I liked a lot of just the non-cancer bread and butter general surgery. I did enjoy minimally invasive to some extent. A lot of that. There's a lot of development in that field nowadays. In the end, I ended up settling on surgical critical care, which a lot of people associate with trauma as well. So that's the fellowship I did. I ended up choosing surgical critical care at UAB in Birmingham and loved it. It's gives you a bunch of different directions. You can do critical care. At some point, if you feel like you don't want to do surgery anymore, you can just go be an intensivist.
Yes.
You can do trauma, as well as hybrid models from there. And I've fallen into more of a trauma route just from the nature of where things go. But what I really enjoy doing is more emergency general surgery and critical care. So it's kind of a tripod. What I do now is surgical critical care, trauma, and emergency general surgery.
Yeah, and I really want to double click on all that. So first of all, you go to probably one of the top three, if not top two, premier flagship universities in the Southeast, UAB, which is not necessarily known until you get into the medical field of how fantastic of a program that is. And doing surgical critical care. Now, I think the lay doctor, even at this point, would kind of combine those two a lot with surgical critical care and trauma. But do you have some delineation in your mind? Is that trauma surgery versus surgical critical care? It seemed like you had said that we could call it trauma surgery, but is there a delineation in your mind?
It's a weird dynamic because when you tell people you do surgical critical care, they associate it a lot with trauma, which is not necessarily wrong, because a lot of the programs that teach surgical critical care fellowships through ACGME and whatnot are very heavy trauma focused. Mm-hmm. Not all, but UAB obviously has a lot of trauma, and a lot of places tends to be weighted on trauma, and so you get a lot of experience from that standpoint. And then it just depends what your interests are. Just like a lot of places, you got to find your own niche.
Yeah. Well, it seems like an interesting one to have there. Mm-hmm. And it seemed like your grandfather, primary care. Certainly, there's emergencies that can happen in that, but perhaps a little bit more laid back field.
Yeah.
That's certainly what I thought I was going into whenever I started. And then as things go on, I actually enjoyed critical care more than I thought that I would.
I did too. I was surprised by that. I really enjoyed it during training and
right. And one of the things that I liked about it is that like you had more control over things than perhaps you would elsewhere. But still, you're dealing with some would say cynically in our field, you've got sick patients and not sick patients. And the sick patients can die within 24 hours and the rest fall into not sick, okay? And so now you're gonna start dealing with sick patients, or at least that's gonna be where you make your profession here. That's an interesting transition to make.
Kind of backtracking a little bit that led my direction. I've always, like I said, liked reading, and I've always been very interested in health and nutrition. Read a lot of books about that. And so as going through medical school, my grandfather in the back of my mind, family physicians, a lot of primary care is trying to focus on long-term wellness, which many patients don't listen to
ignore,
the recommendations.
Yes. Believe you me. Yeah.
I got very frustrated in the medical school time frame with, it's like, this is all they need to do and they're going to be fine. And so I didn't like the idea of struggling with chronic disease from a primary care standpoint for my career. I was like, what can I do that's not going to have to manage ongoing chronic disease just wasn't me. There's people who do it and do it great.
Yes.
That wasn't what I was interested in. So I started looking more acute, and that was also how I ended up going into surgery and then surgical critical care, where you're doing critical care, you're doing emergency surgery, you're doing trauma. You can still help people. You're not worrying about their whole life, but people need somebody to help in and of that moment.
I'm going to bridge you over troubled waters so we can worry about that other stuff later.
Exactly. So that was a big part of my decision pathway as well.
Yeah. I've always been fascinated by trauma because it seems to probably many doctors, but certainly the lay public, that would be overwhelming. You have no idea what's really coming in. You've got a gunshot wound. That'll be the call over. EMS is coming with a gunshot wound. You don't really even know where the gunshot is.
No.
You're going to find this out probably on the fly as they're coming in, maybe even with chest compressions going on at the same time, versus somebody who's just had an explosive aneurysm. I mean, there's a variety of different things of traumas that can come in, MVCs that can come in, where you have no idea. There's going to be a combination of broken bones and internal injuries, visceral injuries, and bleeding diatheses, and all of these things are coming in at once. How do you even sort that as a trauma surgeon when they're coming in like this?
I think you fall back to your protocols and your recipes per se. It's like years ago they came out with ACLS for cardiac. We have ATLS for trauma, advanced trauma life support, and it's basically an algorithm, and it gives you the guides. You go through these primary steps, there's these middle ground steps, and there's these next steps, and it's like, if this, then this, and at some point it's like, if you can't get through those first 3 steps, then you go back and repeat the first 3 steps, and you don't move on to the next step until you're done.
You stabilize.
Yeah, you stabilize those first 3 steps, and at any point during the emergency situation, you can go to the operating room, you can do maneuvers in the trauma bay, whatever it may be. But you fall back on your protocols. And only once you get really comfortable with that, and it even took me several years out of training to get more comfortable with that, then you can be a little more nuanced, and you still have your guidebook, but then you know when to step away from it. That's the point. It's like, we have these rules, we have these protocols, they're there to provide comfort, a framework, but at some point you've got to step away too. So.
That's the art. When you realize that you're stepping outside of guidelines and you know what you're doing, that's a really interesting place. It's a good place. But do you find that the training just snaps in for you? Like all of a sudden a trauma comes into you. Hey, Dr. O'Neill, we've got a trauma coming in, Bay 4, 5 minutes out, gunshot wound. Do you find yourself just immediately going into that, I know exactly what I'm going to do?
That's the other good thing about where you work as well. At established trauma centers, which we do have here in Panama City.
Indeed, we do.
It's a level 2 trauma center. It's not just you and your training, but the whole facility is supposed to be on board. So you're supposed to, in theory, have trauma nurses, ED docs. Everybody's supposed to be on the same page. Everybody's been through some element of training for a trauma patient, so you're not having to, rewrite the book every single patient. So a lot of things are happening. But yeah, you have to get in that mindset, and you have to make sure everybody's in that mindset. It's obvious when there's a new person, whether it's a nurse, a tech, or whatnot, that hasn't experienced that, because you can overcome it, obviously, but you can tell whenever somebody's out of their element.
Well, and it seems like, you've got to kind of be quarterback, leader, position, and everybody should know their role. Like, no, we need 2 large bore IVs right now. Don't worry about anything else, because the other stuff is going to be taken care of from somebody else. And, let's get blood supply online,
On that note, too, is like whenever you're taking the test in medical school, whatnot, it's like, what's the next best step? I hated those questions. Hated those questions.
All of them, yes.
Yeah, because it's like, we're literally going to do all of these, and they're almost always going to happen at the exact same time.
Yes.
And that's what's going on in the trauma bay. A lot of these things are happening at the same time, but if you have to sit somebody down, it's like, we're going to do this first, and then this, and then this, and then this. But in practice, a lot of them occur simultaneously.
It should snap. I've found for myself in code situations, the first rule of a code is take your own pulse. I found actually I get a lot more calm. It's some sort of success breeds some confidence in that. But I find I can take a breath here. I can kind of take piece of the situation.
And when the person who's in charge of the room is calm, it really diffuses down to everybody else.
Yes.
And I've noticed that through training as well. And I've tried to manifest that in my own practice, and I feel like I've been mostly successful with that. But you can definitely, from training, see the rooms, whether it's a code situation or big trauma. Everybody's on the same page, but the people who are a little more frantic or a little loud or aggressive tend to have a different scenario.
Try and talk to the medical students about yelling never helps anything in these situations. It doesn't. You can be calm. You can talk to the people. You can get feedback. Believe it or not, you can even joke in those situations. That's actually helpful to kind of to take the temperature down a little bit. But so you and again, trauma is large and broad. You can have people that fall from a ladder. You can have a house collapse on people.
We separated into 2 categories roughly: blunt and penetrating. Penetrating obviously being stabbing, shooting, impalements, and then blunt falls from a ladder or car accidents. And you can have combined a car accident, you can have a blunt trauma, and then also get impaled with something.
Sure,
so it's not always isolated, but in general, blunt versus penetrating. And it kind of lets you know pathways in your mind.
It starts to get your algorithm cooking for the things that you're kind of training. And I've talked about this before on the podcast. It's awesome when you're in the middle of a procedure and like you're just flowing. You're almost not even thinking, just it's a flow state of this goes here. Your body kind of starts to do the right things.
And especially when you have a good team and you've worked with them before. During we might talk about this at some point, but during my early time as an attending out of training, I did locums for a little bit. And so you pop in and you do all this, which you have all your protocols and algorithms, but it's with people you don't know.
Yes.
And so you fall back on the algorithms and the protocols and the system, but it's so much better when you have those people you know their capabilities, you can trust them, and they know you as well.
They know what you're going to want. They know exactly, they can hand you the instrument that you're looking for immediately. And that's really amazing. There's also an element I'm going to always call back to the things that I know how to do that I try and talk to medical students about, which is on EKGs. Don't jump right to the most conspicuous finding. You need to go algorithmically there, because otherwise you're going to miss something. So I would imagine there's something similar here. You're so worried about this gunshot wound over here that could have caused visceral organ damage, but you can miss the collapsed lung or something like that you've got to kind of make sure that you're going through your
like
steps.
reading the chest x-ray. You don't start to the most obvious finding unless you absolutely have to, but you go through it in your mind, kind of like the EKG or the ATLS protocols, ABCs. we try to make you dumb it down a little bit. Not everybody's a cardiologist, so
We're way dumber than that. What are you talking about? So
airway, breathing, circulation, disability, environment. So you go through your ABCs, and like I mentioned earlier, if you can't get through it, you start over at A again and try to keep it very simple.
Yeah, long before you go towards your secondary survey and other things that are going on there. So now, this can also be, you've got the scientifically curious doctor mind, which is that, the ABCs. I have to take care of this patient. I have to get them stabilized. I have to take care of the acute surgical. I've got to decide whether or not we're going to go into surgery. But also these are, by definition, incredibly traumatic events psychiatrically. And you're going to have families that you're going to have to deal with, and you're going to have to give some really terrible news. That's just the nature of the beast.
Obviously people can die in the trauma bay despite all your efforts. So that immediate process is hard because it's the shock right there. And like you said, you have to talk with family, and we did everything. There was nothing we can do. And you learn a lot of empathy, sympathy, trying to put yourself in their place. And that's something they don't really teach you in training much either. Kind of have to pick that one up on your way as you go along to some extent. And I think they could probably do a better job of training or exposing that.
Yeah, I think they could. I'm not entirely certain how. You kind of just have to throw yourself into that.
I had a very good, I feel like I had a very good, well-rounded experience. I remember one time in medical school, not one time, but one of the rotations I did was a hospice rotation. I chose to do it just from that standpoint, try and get a little bit better breath with people who deal with this often. And even during a fellowship, I had a very good program director who's like, you have 9 months that we have to do the core of your fellowship. 9 months. It's like, then there's 3 months. It's like, if you want to just continue doing the core training, we can do the core training. But what are you interested in? What do you want to do? What do you think is going to better develop your knowledge base? And I ended up choosing a couple different things, but I went and did pathology. And so we did autopsies, and I learned how to do like a lot of our post-trauma autopsies. I went and helped out with that. Did some imaging stuff too, like some advanced imaging. I'm by no means capable of reading an echocardiogram, but I can do it on the spot bedside echoes.
Yes, but also what a dimension that brings to you. To understand what tamponade is. Again, if you've got blood or any other fluid that's surrounding within the pericardium that's keeping the heart from functioning, it doesn't matter if you're bleeding anywhere else. It doesn't matter if you're not even oxygenating. If your heart stops, okay, game over. And so having to be able to recognize that and utilizing different tools really is a great.
We had one particular patient I remember in training who was this big muscular guy who, I don't know if it was a shotgun or a BB gun, but one BB penetrated his chest into his myocardial area, and we watched him develop cardiac tamponade in front of our eyes as he was still awake and talking. We saw the pericardial blood, so we made attempts to go to the operating room, which we were successful. But as we're in the operating room, going to sleep, we essentially had to do a crash sternotomy on him at that time, which was very, exciting.
Yes,
but,
exciting.
I've literally watched cardiac tamponade develop, and all the things you hear about pulsus paradoxus and whatnot. It was turning blue. It was educational.
And then you don't ever forget that. Mm-hmm. And then you can kind of see when you learn about these pathologies, you learn them kind of almost in discrete steps of you've got Kussmaul breathing, and then you've got pulsus paradoxus, and then you've got your tachypnea, and kind of these other things that kind of build up to it. And then you realize that's actually a contiguous spectrum of this manifestation of a disease. And it's really, oh, now I see it. This person's very sick, but still, now I see it.
And just one little tiny injury, there's one little BB. That's all it takes.
Yeah, and we'll kind of come around to some futuristic topics here, but I've been thinking a little bit more about that lately. Of just as we're getting closer and closer to our future, where we escape longevity velocity, as it is said, it does strike me sometimes, and you've seen this writ large, how fragile life can be.
Oh, yes. And that was, we were starting to talk about those family discussions. That was the acute ones. The ones that are a little more challenging are the ones, and that's the other thing I really like about this field is You get the patient, and it's not chronic care, but you get the patient in the hospital, whether it's emergency general surgery, somebody's septic, or a trauma patient where it's a bad injury. You admit them in the intensive care unit, you operate on them, or you get help from your colleagues to operate on them. You take care of them their whole length of the hospital stay and into the regular floor, and then discharge, follow them up as an outpatient. But you also have those hard conversations at some point in the ICU where, whether it's brain death or a non-survivable situation, or the patient's aged and maybe wouldn't want some of these things done on them. So then you have to learn how to talk with families about a lot of those situations. And that's the whole thing with hospice. You change the focus from quantity of life as opposed to quality of life. And you get to have all kinds of discussions with people. And there are certain people that can do it better than others.
That's true. And it's changing the goals of care, from fixing everything to making it as least symptomatic as possible. Those are really interesting and heartfelt conversations that you have to have. And honestly, that strikes me as more of an internal medicine side of things than it is surgical side. That's not typical of things that I hear from surgeons.
One of the, I remember this from MUSC, one of the physicians I trained under, he was one of the trauma and surgical critical care docs, Dr. Erickson, and he basically told me at some point during that first year, is like, a surgical intensivist is basically a medical intensivist with a knife.
Yeah. Who can get out of trouble if there is something that comes up.
And so there is a lot more of medicine as opposed to surgery in critical care, but obviously it's
once you get to pressor support and inotropes, medications that keep you alive when you're very, very, very sick. Vent management. That's very medicine side. Now, I would also imagine in the surgical critical care world, and I think I've heard this about you, is that you are some of the surgeons' best friends too, because you will be managing a lot of patients that are critically ill while surgeons are going to go do other surgeries and other things like that. Is that, would you think about
relating to talking with Chris recently, I believe. But,
no, I don't like to talk to him, but
so surgical critical care doesn't just encompass trauma patients. It could be any bad surgical patient, as well as some planned surgeries. Cardiac surgery can fall under that. Transplant surgery can fall under that. So it depends on where you go as to what type of surgical intensivist you may find. Here in our small community, we're a little more broad-based in general. But yes, so some patient comes in, whatever it may be, diverticulitis, their sepsis, septic, they get surgery by one of my partners or whatnot, and then they need the intensive care unit. And so they'll give me a call and say, hey, this is what happened, this is what what's going on, can you help out with this patient? And so we'll consult from an intensivist standpoint and get them through their sepsis, shock, whatever it may be. And it's like, we polished this up for you. It's all yours now. We're sending them out of the unit.
Well, and so that's a wonderful transition point to have you that can kind of focus in on the things that, because it's kind of, you're thinking in different quadrants of your brain. You're kind of thinking about things a little bit differently as you're going from the medicine and, intensive care side to the surgical side. So it's kind of turning on different parts of your brain. Like,
I'm very bad at quoting data as well, but they have done studies over the past years, couple decades, that critical surgical patients who are taken care of by surgically trained intensivists have a better overall outcome.
I'm sure.
When compared to medical intensivists. And it's not giant margins, but it's a statistically significant improvement.
Yeah.
And it's not across the board either. There's nuances.
I can imagine. And it's also probably getting your team focused in on the right thing. When you get a lot of people moving together to kind of focus on one different area, that's a lot better. But some major sickness that you wouldn't really realize, certainly from the lay public, things like ischemic bowel, or having to do some sort of open abdominal repair and keep it open afterwards. Those are kind of intense situations. You need somebody that can manage all the other things. You don't think about, well, how do you get nutrition in that standpoint? How do you keep your IV fluids there, because your body will want to get rid of a lot of that. So that's why we have pros that can do this kind of stuff.
And just like every specialty, you start to take some of those things for granted. And then you're like, oh wait, they need me to do this part.
No, that's a good point, because we tend to fall from, when you get consulted from the ER, it's like, well, of course this is AV nodal reentrant tachycardia. How could you not know that? And then you got to take a step back. This is what I see all the time. They're seeing trillions of other things that are coming in that are kind of all different ways. So that subspecialty niche is sometimes nice.
Yeah,
So,
and that's why you consult people. It's like, I don't see this all the time. I just need a little help.
yeah, and I do love that esprit de corps about medicine in general, which is that. I tell the medical students, look, if you're going to consult somebody, have a well-formed question. If you're out over your skis and you need help, send a beacon out. Everybody will come running. Mm-hmm. Everybody will come and say, yeah, dude, I heard there was somebody really sick. Well, what kind of help do you need? And we'll bring everybody to bear on the situation.
And one of the terms we use is like, the ship is sinking. Let's get people on board to help prevent the ship from sinking. Let's not wait till the ship is sunk.
No. Don't try and raise the ship from and bring them on now.
Let's bring them on now. If this ship's going down, we're going down together.
We're going to do this. Yeah, exactly. We'll at least be playing music while we do it. So now let's take it. So you finish your fellowship training. Mm-hmm. Where did you decide to go from there?
So I mentioned we always wanted to go home to Louisiana, mm-hmm. and looking around Louisiana, I'm from closer to Baton Rouge. Mm-hmm. My wife's from closer to Lafayette.
Yes. It's a nice little corridor there on the I-10. Yeah.
Yes.
Mm-hmm.
Yes. And I never wanted to be in a big city. I never wanted to be at a big. I mentioned already I had a bad taste of bench research.
Yes.
So I was trying to look for a place that didn't overly involve like a research-heavy component.
Not really an academic center that you're looking for.
Yeah, so I wasn't looking for academic center. And so New Orleans had a lot of academic center. Mm-hmm. We didn't really want to live there per se. At that point, we had 3 children as well. I neglected to mention that. So interestingly enough, I moved away, Jenny and I, just the 2 of us. And at some point we said, we had some family members who had some trouble getting pregnant, and it's like, well, we don't know if that's going to happen to us. It's like, let's just stop trying. So intern year of surgery residency, Jenny got pregnant with twins. So neither one of us.
What a perfect time.
Yes. Neither one of us remember much about intern year. Whether
nobody's going to sleep here. All right.
Nobody's sleeping here. So it was, it's like the things you just get through and put up with, and like you think back now, it's like I don't want to do that again.
Yes, exactly. I don't know that was fun, but certainly it's formative.
Yes, it was definitely formative. So anyway, at this point at UAB, we have 3 children. New Orleans is a great place, but we had only lived there for school. Mm-hmm. We didn't have any other true family there, so we didn't want to necessarily live there. Didn't want to be in an academic center per se. Baton Rouge was an option, but it's kind of a mess of a city too. It's got LSU, which is amazing, but
outside of that, it's not. Post-Katrina, it got weird. So
and it's that grand thing. It takes an hour to get to Baton Rouge from Baton Rouge. Anywhere you want to go.
Somehow, yeah.
I'm not a big fan of traffic, that daily grind traffic.
Oh man, and that'll have it. Yeah.
Lafayette was a good middle ground for both of us. We had a bunch of family and peripheral connections there, and they had a good hospital at the time. It was a level 2, I think, and it was aspiring to be fully ACS, American College certified. So it was a good fit, and I had some connections there. In the end, it turned out not to be a great situation. The surgery and taking care of patients was amazing, but it was the setup, and they still are struggling with some of the organization of that program.
Yeah, and I think this is an important point to talk about for graduates that are coming from your residency or your fellowship that goes out into your first job. You want to make a really thoughtful approach to your first job. You certainly want to, you're going to get a brand new contract with more money than you've ever known what to do with, and that's going to be an immediate satisfaction in a lot of different ways. But there's a reason why I call it a first job. It's very likely to change. And you might make some mistake because you've been so worried for so long about, can I be a trauma surgeon? Mm-hmm. Can I do this thing, that you haven't had a lot of business insight or the questions even to ask or how to even think about what this job would be like. It's a whole different world that you're not used to.
I think at some point in 3rd or 4th year of fellowship of residency, I went to the American College of Surgeons conference. It's the mecca for surgery. It's huge. And I went to one of the resident presentations at that point. And at the time, this is over a decade ago now. Might be longer than that. But the average job from an out of training surgeon was 2.7 years. And it's like, as we moved to Lafayette, I was like, well, that's not going to be me. This is home. We're going to be here for, I lasted 5, so almost 5.
So it was longer than that. It was almost 2x. But still, there's no shame in that. And that's what I want to kind of take. You're going to have to kind of sometimes iterate to find the thing that's going to work with you. There's plenty. I mean, the stories are long and glorious about how many times people have been promised certain things and different contractual obligations, and then the wool gets pulled over your eyes, and you come out and you're like, wait, none of that was true.
I was hired by a used car salesman, essentially. It's
I thought you were doing surgery this whole time.
Yeah, I bought a lemon.
You bought a lemon. Okay, well, interestingly enough, so you had this experience where I've said before on here, my father-in-law says experience is what you get when you don't get what you wanted. So you had this experience.
It was great. And I remember starting it, and I loved Lafayette. I loved the hospital, loved the people I worked with. Got to do some really cool, crazy surgery. I didn't realize how violent of a region Louisiana was there. We were doing a lot of violent crime.
That is true Cajun territory. Yes. New Orleans is not Cajun. Lafayette and the surrounding territories are Cajun.
That was surprising how much penetrating trauma. Anyway, but I remember my first real case from a trauma standpoint at that hospital. I'm just popping in there. It's my first day. I'm in the doctor's lounge trying to figure out how the computer works. And I get a call from my partner who I'd never met yet.
Oh.
I hadn't met this one. And he's like, are you going to come down to the trauma bay? I was like, I can. Why? He's like, there's a trauma here and I want to leave. I was like, oh, and
I guess I will. Okay.
I'm in the doctor's lounge. I'd been to the trauma bay, but I still don't know this hospital well, so I don't know how to get there.
Yeah.
And so I finally get there, and I don't really know what the presentation was, but evidently there was these 3 large men under their carport. Large men, many 100-pound men, just having a little conversation, and somebody came in with an AK-47 and shot them. And 2 of them ended up being
happens all the time.
Yeah. I think had to go with different surgeons, vascular, orthopedics, or whatnot. But one, and my partner looked at me as like, "You got this?" And I'm like, "Again, first day, out of training."
I guess so.
And I was like, "I guess so." And he pats me on the back. I was like, "All right, call me if you need." And he just leaves. And at that point, it felt like an hour, but I just stood there and was like, took a deep breath and was like, let's do this.
Here we are. What do you do with the code? Take your own pulse. Yeah.
And you just flip a switch. And
I remember calling my program director after I'd done the first left and right heart catheterization after training, as a real cardiologist. And I called him and I was like, man, I did it and the patient's alive and everything. And he goes, they all get easier after this.
Yes.
And so that kind of calmed me down. But either way, but you're in it now and you're doing it. You're doing the thing that you were kind of trained to do. And the 7 years of training feels like maybe it was enough-ish.
That's interesting too, is because general surgery, you're there for many years. You think you're going to see
many
everything, and then you realize you don't see everything. And some of the rare general surgery things, you hear about your cohorts and trainings, like, oh, I've done 6 of these, and 6 in some cases is a lot. I had never done a femoral hernia.
Oh, okay.
In training. I don't know why. Just missed it.
Wow.
All my co-chiefs had done several. It's like, sure, it never happened to me in training.
Okay.
Have no idea. But studying for the boards after general surgery residency, because there's a few just traditional cases you have to know.
Sure.
I studied the inguinal canal to where I could just bread and butter, backward, forward. My first general surgery case in Lafayette.
Out of training.
Was an incarcerated femoral hernia. And you sit there and you're just look at what is going on.
It was, okay, this is what we're going to do.
And this was it worked out great. Everything went fine. And I mean, I've operated in that area plenty of times. So it's not like I didn't know what to do, but it's just wow, this is gonna come and get you.
It's kind of a confidence boost too, in that you can go into uncharted territories. You're not going to dive way out, but you can go into some uncharted territories and be like, okay, I can get through this. I'm not going to.
Just got to laugh at yourself sometimes.
Oh man, 100%. Of course, that would be the first case. Yes. Why wouldn't it be?
Why wouldn't it be? So that was my introduction to, big boy surgery, where there's, you still have partners, but there's no attending at your back. You're out of training. And
That's right.
from there, like you said, everything got easier.
Yeah.
And that's not necessarily easier, but you changed at that time. So.
Yeah, and so you're figuring out how to be a dad and a husband and a real life doctor and kind of change your life a little bit. After 5 years of you working out that working relationship wasn't going to work for you, tell me about where we went from there.
One of the things I really liked about the job where I was, except for the employment situation is what soured me and caused me to end up leaving. But it was a rural-ish town, Lafayette. We had a university, and we also got the surgical residents from LSU New Orleans. They would come rotate through us.
Sure.
So I was technically an assistant professor of some sort on paper.
Yes.
I think they just needed a warm body in the hospital too.
I've noticed the longer that title gets, the less prestigious it is.
That's exactly what it was. But I got to train residents, and we had first years and I think fourth years, and every now and then there was like a second or third year that would pop in for the most part. I'm probably forgetting exactly how that goes. But I really loved working with residents. I mean, I was at ETSU and then UAB. It's very resident heavy. And I was just like almost one more level. You get to work with the residents. And I got to meet several good people over the 5 years I was there. At the end of whenever I was realizing I'm looking for a new job, LSU is a big place. They have a big community. The residents at Lafayette started to hear that I was looking at leaving. Well, they called some of their other residents who turned out to be Chris Johnson and Allie Moody and Cologne Castellucci, who were also employed at this hospital here. And they all individually called me over the course of a few weeks and said, hey, come check this place out. We're looking for such and such in your job. And I'm like, I'm not moving to Panama City. And at some point during that whole several week process, it's like, all right, I'm actively interviewing at places. We'll come look.
Sure.
And Jenny, again, she'd been a trooper throughout all this training. I cannot emphasize enough how much support, like she was the backbone through all of this. But whenever we had finally gotten home, I promised her we're going to be home.
We're staying.
She didn't want to leave.
Of course.
And she aggressively didn't want to leave. And at some point, it's like, baby, I don't care where we go. I don't care what we do. But it's like, I can't work here anymore. Yeah. And at some point, she kind of got on board. We went on a few interviews, and she just wasn't happy about any of them. And we come to Panama City, and we were driving around looking at the hospital. She's like, all right, this is going to happen. It's like, I like this place. We could live here. I'm like, done, sign. And, nowhere's perfect. No hospital system's perfect. No practice is perfect.
Of course.
Like I mentioned, I really loved where I worked, where we lived, family, and the hospital thing. The employment situation got a little onerous. And here, it's not perfect, but it is perfect enough,
Yeah, and I do like the vibe check that you can do for places, because this is, a very similar story that my wife, previous podcast guest, had said about, she came here interviewing, not really wanting to come here. She didn't want to come back home or anything, but then she came here and was like, I actually liked it and everything. And I love this place. This is home as far as I'm concerned. And so
it's coming up on 3 years for us. And, at this point, whenever we moved, she's like, how long are we going to be here? It's like, at this point, it's like, I don't know. We're just going to take it one day at a time. We don't anticipate leaving, but
of course.
At this I didn't anticipate leaving Lafayette either.
No,
we've already bought and sold 2 Forever homes.
How many Forever homes can you have?
Yeah, I don't know.
We'll find out.
It's not here. It's like we just bought a home here, and so we're not calling it anything. It's the place we live right now.
It's the place that you live for right now. No, and again, I think you got to find your professional fulfillment, but also you got to enjoy the people that you're working with. You got to love going to work. You got to love coming home. Those are really important things. So, well, our community's a lot better because you're here. So, all right, well, I think we got through your life. Let's talk about some other stuff for a little bit. You ready for it?
Sure. I will say one thing that was really helpful about moving here, we didn't have as strong a community in Louisiana, Lafayette, where I was, from the physician standpoint. And I think it was actually Chris and Allie, I can't remember who, but pointed out ECMA to me. I was like, you should join this. And I don't know what it is, sure. And so I joined and then really fell in love with the collaboration with the ECMA.
Yes.
It was helpful for a new person to the area, but also it's fun, for lack of a better way to describe it. Good community. I really enjoy the people I've met and the goals of the group.
Yeah, and it's a very supportive environment, but it also kind of focuses in on, we want doctors to be able to treat patients the way that they want to be. We want to empower doctors to be able to do the things that they want to do, and that includes having a life and having a community and having kind of a very wholesome kind of environment to do the things that we do here. So it really was important to me too. So and
it had nothing to do with me coming here, but then after I got here, it's like, this is
great.
amazing.
Yeah, exactly.
I was like, I wish I would have known about this before, because it just would have cemented the deal. You know?
What a resource. And now you find yourself, you are our newest and youngest board member here for Emerald Coast Medical
There's some
Association.
bad judgment on the decision makers on that, but you know.
Well, enough about me. Let's talk about you for a little bit, okay? So now, tell me what does a day in the life of your practice now look like?
So obviously, trauma, emergency general surgery, surgical critical care is not the traditional Monday to Friday 9 to 5 model.
Yeah, and I don't know that. So shift work is.
It's essentially shift work. It's one of the few, if not, things are changing a little bit, but it's one of the few, if not only, surgical fields that is true traditional shift work, almost like an ER or whatnot. And we have to have 24/7 coverage, and not just 24/7 primary coverage. We also have to have 24/7 backup coverage, and this is at every verified trauma center.
Right.
So you have to have enough people that can manage 24/7 primary and backup coverage, and at bigger centers, obviously, there's more. But
sure.
So it's not a set schedule, and there's a bunch of different models, but we don't have a set schedule. But in general, it's work a week, off a week, and we do 12-hour shifts over here. And so I'm on for 12 hours primary, whether it's daytime or nighttime, and then the opposing 12 hours I'm on backup call. So in general, work a week, off a week, primary call, backup call during that time. And that's the schedule per se.
Yeah.
But like I said, it's not a rigid Monday through Sunday. It's
sure, there's going to be
variable.
vacations and times where you need to cover a little bit more than that or less than that. So, I'm not certain the lay public realizes how incredibly important it is to have trauma in your environment and in your community. I mean,
it's a huge deal, and it's neglected somewhat. It's like nobody needs a trauma surgeon until they do.
Need it.
Same thing. Nobody needs a heart cath emergently until like you're with an elephant on your chest in the emergency room. So it's somewhat underappreciated. We do a lot. Trauma, I think, still, as of several years ago, was the 4th leading cause of death for all comers. So once you get past cardiovascular disease, cancer, trauma's right there. And for the younger population, under than 45, more men than women, but still, it's the leading cause of death.
Yes.
So it's a huge deal, even in smaller communities. And I mentioned Lafayette was a more dangerous, penetrating, violent crime. Panama City is much safer.
This is good to know.
It's good to know. So it's a great place to raise a family.
There's a lot of things that you can talk about, and I have a huge talk to my patients about prevention. It's much easier to prevent cardiovascular disease than it is to actually treat it. And we can prevent a lot of things from a cancer perspective by decreasing our risk factors, exercising, watching our diet, no smoking, that kind of stuff can certainly help. Preventing trauma is a little bit different.
It is different. Part of it has to be policy, and some of these things have developed over literally decades. Way back when cars came around, cars were cars. There weren't seat belts, but there also weren't interstates. Then you develop interstates, people are going faster. Seatbelt laws got developed at that time. Deaths dropped down. I think we're going to see an interesting shift because car accidents are very prominent. I think we're going to see an interesting shift in the coming decade. We're talking about technology, self-driving cars, and all these robotaxis, whatnot. It's going to dramatically decrease a lot of the car accidents,
hopefully.
Which is only good.
Yeah, great. One place that I've noticed it actually was going skiing 20 years ago versus skiing now, where it was you were really uncool to wear a helmet then, and now everybody wears it. It's very, very few and far between that you're not wearing a helmet. I think it's for the better.
A lot of our business here locally would not be here if people wore helmets. Whether it's laws regulating motorcycle helmets or whatnot.
Yes.
We would have a lot less injuries if people just wore helmet. It's crazy.
Yes.
But that's part of the pre-prevention is seat belts, wear a helmet. One thing that's come about over the past many years, I'm sure you've seen it too, is the advent of these e-bikes and all these battery-powered situations. Well, people who didn't formerly wear helmets on bikes don't wear helmets on these e-bikes. Some of these e-bikes can get very fast. I mean, they're in the level of motorcycles to some extent. So we're seeing a lot locally, because you can rent an e-bike or steal an e-bike on the beach for nothing. And we're seeing a lot of people who are coming in after these multiple times a week, devastating e-bike injuries. We're not a pediatric trauma center, but we still do pediatric stabilization, triage, and then we'll send
stabilize,
out.
Yes.
And so, fortunately, we don't see as many kids. We see more adults, but it's prominent out there. So a lot of that prevention is, and that's another thing about being a trauma center, is we actually have people at our hospital who are strictly focused on prevention. They'll go. We had a helmet giveaway during one of the races where we had in our hallway, we had like 24 boxes of bicycle helmets, all different sizes.
Yeah.
So it was a helmet giveaway. One of the big things through the American College of Surgeons that you may have seen that they've been promoting over the past many years is called Stop the Bleed. It's just bystanders. If somebody in a car accident, how to apply a tourniquet, pressure, things that we take for granted, but in the field, just like bystander CPR, if somebody knows how to do it, they can start it. But if you don't know how to do it, same thing with somebody's bleeding to death, and you don't know that you need to just put pressure on there. It sounds simple, but it saves some lives.
Indeed. Well, and also, be careful as we get older going up on ladders.
Yes.
I'm sure we get some occasional boat trauma, and usually that's probably got some alcohol related to it.
There is a very big preponderance of substance abuse in trauma, but it's not 100%. Right. But a lot of our trauma patients, whether it's substance abuse, alcohol, drugs, whatnot, one thing that's interesting here as opposed to back where in Lafayette or even where I trained, this is a tourist destination area. So we get some interesting seasonal traumas. You get your snowbirds who come in during the wintertime, and we actually have some people who come here to convalesce after an injury or a surgery, and they're not used to the condo that they're in, and then they trip and fall or fall down the stairs, or they are going to celebrate and they have a drink at dinner, which they don't normally do. And
that's right.
Any number of things. One thing that we've seen that almost happens every year is you get, I'm making up this story, but in my mind, this is how it goes. Somebody's driven many hours to get to the beach. They get their condo. They run out to the beach. They see the water. It's beautiful. And then they dive in and they break their neck on a sandbar and then become a quadriplegic. We see some of these things.
Well, and then
routinely.
There's the spring break crowd that will almost annually have a fall from a balcony too, which is,
we get a lot of falls, whatever it may be. And I said there's less violent crime. There still is violent crime. So we still, on occasion, see gunshot wounds or stabbings. The prisons here, I don't know what they do in the prisons here, but we have a lot of stabbings from the prison.
Shank or be shanked, I guess. Well, and again, it denotes how necessary it is to have a good trauma unit, a good trauma-trained surgeons and staff and people that are ready for this kind of thing, because that's going to be quite literally life-saving. And that's really where you measure yourself from the trauma perspective is, are we saving lives? And you guys are.
And we actually have data to prove that. That's the other thing about being a verified trauma center is not only are you supposed to, it's a huge deal. There's a 200-300 page book that describes what you have to do to be a trauma center. Not just have trauma surgeons, but orthopedic surgeons, neurosurgeons. You have to have the capability of 24/7 OR, blood banks, EMS. There's a whole list of things. But we have all of that here.
Yes.
And it doesn't it spreads out to these other departments. Because we're capable to do trauma, we can do all these other things better too. So there's a lot of peripheral benefits of being a trauma center.
Of having this. Yeah, exactly. One of the other things that I love about the esprit de corps from trauma surgical perspective is that if there's a massive casualty event, I don't care if you're on call, if you're not on call, you're going to come and you're going to go take care of the situation. It's a clearing call to everybody, and everybody says, okay, we're all coming in to do this kind of thing. And so I've seen that a couple times, and it's always really amazing to see.
We've had a couple of them here that, a school bus, we had a school bus crash one day, and so we had a bunch of little kids come in, and they fortunately it was okay. But, we had to send a few people out, but
you don't know what you're going to get.
You don't know what you're going to get.
You don't know what you're going to get, and you also have to be careful about the post-trauma adrenaline, hey, this person's walking around, and actually they're walking around on a shattered femur or something like that, and then they
crash.
Yeah. So, well, I'm happy to have you around. Now, we're going to talk a little bit about the future here. What is the biggest issue facing your specialty? And I'm going to call that trauma surgery in the near future.
Locally or nationally, or
I think you can go either way. You can do yes and.
One of the things across the board, and I think, like we mentioned, there's a lot of people who are involved in trauma, substance abuse, whatnot. These people don't tend to have the best financial system. So a lot of the times for hospitals, locally as well as everywhere else, trauma tends to be run in the red.
Yes.
And so you've got to have the special hospital that does this, and there are other incentives, whatnot. But it doesn't tend to be the most profitable endeavor for a hospital.
That's a really great point because, I mean, as a community, as a society, we want somebody there 24/7 that's ready for whenever trauma occurs, because it doesn't just happen at 3:00 on Tuesday afternoon. It's not. I mean, it happens then too, but it'll happen in the middle of the night. So we as a society want that. There's high value in having that. We have to find some way to remunerate hospitals and physicians and teams for doing that, for this very valuable service that you guys provide.
And I'm very naive on a lot of health funding, and I don't think anybody in America's figured it out, because we keep changing things all the time.
That's right.
But there's a way to figure it out, and we should strive to do it because it's necessary.
It is. And, I mean, we keep having this insurance talk, and we're hoping to, with the Emerald Coast Medical Association and this podcast, have some discussions about various different facets of healthcare insurance and how that really shakes out in ways that maybe would be surprising. But this is one area where I think we could really make a huge difference to make this. We want to incentivize healthcare units, hospitals, physicians, to be around for traumas. We want them to be ready and well rested and well paid, frankly, for providing this essential service for, whenever us or our family members get injured or have some other traumatic event. I want you guys there.
Want to be there too. So
okay, good.
I hope they still want us here. That's always the problem too. You have some power being private practice and having your own, but it's not a practical setup in most places.
It's harder to do that private practice unless you're in just a gigantic city that could provide that service consultatively.
So it's not the method here, so we're all employed by the hospital Ascension.
Yeah.
So that's one of the hurdles everywhere. Some things that's coming about in the future that's really interesting is there's a lot of civilian military reciprocity as far as data and research goes. They do things better than us, and then we do things better than them, and we share a lot. As you know, whenever you go give blood donations, they fractionate the blood. So you get packed red blood cells, you get fresh frozen plasma, cryoprecipitate, platelets. So
there's a lot of different components to blood. Blood is not just red blood cells. Yes, it's a lot of great stuff that we need.
So when we transfuse somebody in the hospital and in the civilian life, we start with red blood cells. Well, if we're having to do a lot of transfusion, you're just giving back somebody red blood cells. You're not giving back all those other substances. Whole blood's becoming one of the big areas of massive resuscitation and trauma, using whole blood just
from the get-go. Get all the things that you need in this, yes.
And that's what they do more in the military. And from their standpoint, it was more of a need. The military guys, they have all their blood types. So if they have a problem going on, they'll just over the loudspeaker, everybody who has type A negative blood, come donate, and we're going to use it right now.
Yes.
We can't really do that here. So that's one of the hurdles that they're trying to do. Is a lot of big centers already have been using whole blood. We don't have it here, and it's more from a acquisition and distribution standpoint. There's different shelf lives with whole blood versus component blood and whatnot. So figuring out how to do that everywhere is one of the new and developing areas of trauma and trauma resuscitation.
I love that thought because, there's a couple ways where technology, I think, could potentially help us. First of all, with whole blood substitutes, I can imagine a scenario where we're going to be able to create artificial red blood cells, et cetera, and coagulation factors and other stuff that we could inject that don't necessarily have to be stored in a blood bank or something along those lines.
Oh, the plasma expanders. I don't know if you remember the history of those, but head-of-starches and some of these other things, they were coming about. I'm sure I don't know the full history of them, but they were big whenever I was in training. It turns out they had some adverse consequences, and we typically don't really use these plasma expanders or head-of-starches. But at some point, somebody's going to figure out
Right.
one of these components that can be manufactured essentially, and we won't be as reliant on blood or blood components.
Yes,
and
and
it's not there yet, but there's
storage
people
and
working
extraction
on it.
and other things. No, and I think that is coming around the bend relatively soon.
As soon as somebody cracks that one, that's gonna change things real big.
Yeah, I've also heard about some, I think it's sub-Saharan African delivery with drone to blood products to various different places that I think,
Some of these more remote areas.
yeah, I could imagine a scenario where all of a sudden we're doing that to remote trauma sites, whether that be on the interstate or something somewhere that you can, while we're getting you set up, we're going to start to transfuse you whole blood or something along those lines.
It was interesting in training at ETSU. We're in Johnson City, so right in the heart of the Smokies and Cherokee National
Beautiful
Forest.
area, yeah.
Beautiful area. Well, in some cases, to go 10 miles, it would take you 4 hours. If you had to go around ridges, mountain, whatnot, well, the helicopters hop back and forth, no problem. So for a lot of those areas like that, where we have the technology here, we're not in sub-Saharan Africa.
Right.
I think it's going to be real big for some of these areas that can't, right here in Florida, we're very flat, and you can get wherever you need to go driving, but there's some areas even in our country that could benefit from some of the drone deliveries that you're talking about.
Yeah, I think so. I think there's some brighter days ahead, even for trauma. I mean, there's some really clear-cut brighter days ahead for cardiology, GI, radiology. I think that technology can really help a lot.
And a lot of this stuff bleeds over too, like you're just saying.
Absolutely. So now, how do you think AI is going to integrate into your field?
A lot of the generic ways that it's integrating into everybody's field, you have it at your fingertip. Open Evidence is a great AI program on your phone. I don't know if you've used that app before, but then all the routine AI apps, you have the world at your fingertips.
Yeah.
And if nothing else, it could be the middle of the night and you want that second opinion from a colleague, but it's like, let me just see what this says. And you can sometimes get just a affirmation or maybe a different perspective on a specific patient situation. I've used some of the AI programs myself just with routine patient care, this is what I'm doing with the patient. Let's see what AI says, because my patients are going to be using AI. So
Right.
what is the computer and Googling telling my patients so I can be better informed about how to have that conversation with them? So that's, in my mind, that's some of the generic that everybo's going to use it for across specialties. As far as trauma specific, I don't know yet, but I know it's coming.
Yeah, I recently found with a patient that had Fabry's disease. Now, I wouldn't have known about that. I would have had to really claw back some medical school stuff for this particular disease process, and indeed I had to in terms of looking it up and having some interaction. But I could imagine some interaction that you would have in a trauma scenario where the AI says, "Oh, by the way, this patient has Fabry's disease, so you might want to use more FFP," or something along those lines, where it would just be like, and you've got that kind of, you're still doing the thing that you're doing, the ATLS survey and other things like that, but there's also some background, because, by the way, this patient's got an EF of 10%, we're going to start them on more inotrope-friendly pressor support as opposed to dynamic pressure support.
That's a good point. We have across the board, doesn't matter if you're in a big city or little old Panama City, there's a few specialists that are essential to a trauma center that are hard to come by. One's ophthalmology. You can't always ask an ophthalmologist a question that you may need to ask, so AI is good, but more so what you were getting on. And one problem we had here right at first that's since been fixed was we didn't have an on-call hematologist.
Oh,
and so then you get some of these patients that you could otherwise take care of at your facility, but somebody who's got a chronic lifelong, even something more common, von Willebrand's or hemophilia, or you get some of these rare blood disorders. Like, I know-ish how to manage it. If we had a hematologist here that could help out, no problem. But you have to transfer some of these patients out to a specialty center that has it. Again, like I said, we've since resolved that to make it a little bit easier for us. But you can use AI for some of those rare blood diseases.
Of course. And you want your trauma surgeon thinking about, stopping the bleeding viscous, and not necessarily you need to infuse Adams TS13 for this patient. Like that is a totally different.
And another thing, like we were talking about, there's all kind of developments from the hematology standpoint that are new meds, atoms, whatnot, that they have different. It's like, oh, I've not even heard of that. It's like, yeah, that's new about these past couple of years. So it's again, when you're asking for somebody else's opinion, that's not your level of expertise.
Sure. No, I think because you're kind of, with AI, you've got this potential for having 3,000 very smart doctors that are around you at all times that is looking along this case with you. And so I think there is going to be some benefit for that in all fields. And hopefully it will also bleed into the safety factor too. I mean, maybe we'll know how to better design cars, or maybe with the self-driving cars, we're going to virtually eliminate traffic accidents, which would be great.
And another thing we haven't really touched much on is the psychiatric and psychological impact of not just acute trauma care, but people can get PTSD from a whole range of things.
Of course.
We don't, and it's coming more and more prominently, is telemedicine. I think COVID really pushed a lot of the telemedicine forward. We don't have a psychiatrist or psychologist on staff, but we have telemedicine, and you roll in the TV monitor with the camera and whatnot. And so if we need to emergently have somebody psychiatrically evaluated,
That's right.
we have that means and ability.
But how are the psychiatrists doing their physical exam? No, that's exactly right. I mean, utilizing the tools and the technology to kind of affect different outcomes, but also starting to think about this from a little bit more holistic perspective. I think that's really great. I love to hear this, that we're taking care of patients in the long run.
Yeah, because the acute trauma, a lot of the times, like we talked about, it's exciting. Then you get that case that you've saved a patient, but have you really saved them? And it's hard to have that emergent discussion with the family. It's like, this is a life-changing. They're never going to be the same. The best case we can hope for is they're going to be 24/7 care with a ventilator and a feeding tube. It's like, do everything for my baby, save my baby. And it's like, in that minute, you've got to do it, but then people don't realize the consequences of those initial actions. So there's a lot of aftercare that comes into trauma that I don't mean it this way, but it's a huge burden on the overall health system.
Of course.
Whenever you have a functioning member of society and then they're completely dependent, and it drags the family down. And I've seen it through the years of just, you try and do everything you can, and the patient's alive, but there's different definitions of alive. So.
You're not judging these people. You've seen this writ large. You've seen how this happens and how it can really take on families. And of course, you want to do everything you can to save them. And this is one thing that I try and impress upon, and we can say this now to the lay public. Most every patient makes it out of the surgical OR. Just about every. I mean, a high percentage.
Most patients make it out of the trauma bay.
So we don't lose a lot there.
We've gotten very good at keeping people alive.
I say this from the CT surgical perspective. I mean, valve replacements, LVADs, bypass surgeries, these patients get off the OR table. They just, somehow, amazingly, we've gotten very, very good at that with a combined team approach in a lot of different ways. Now, how they do from there, that's where outcomes start to differ a little bit. But we can get patients in the OR and out of the OR. We can do that. The long-term thing is different implications there. So,
yeah, I've in my career, even with trauma, I've only lost a couple people in the operating room, and it's a bad day for everybody, but it's odd too. I mean, you're there for. You need to be there, but it's what it is.
It's rare, and I think people need to know that more. Our surgeons are pretty talented nowadays. So, what recommendations do you have for young health professionals just beginning their career?
Don't major in biochemistry.
Might second that.
Some of the videos that I've seen, social media aside, I think the young population seems to be a little bit more focused on themselves as well. So a lot I have a little bit.
About looks maxing? Is that what we were talking about? Glad we got to drop this here on the podcast today.
They seem to be a little bit more well-rounded, or not well-rounded, but more focused on themselves. So they're going to take more time for themselves before they commit to an aggressive field like this.
Yeah.
In hindsight, I wish I would have done a more fun major, like we mentioned. Would have been nice to take a year off and travel the world, do something crazy,
Just be well-rounded.
Yeah, be well-rounded.
Yeah. Be a person.
Be a person first, and everything else will fill in. There's no clock. I mean, I went from school to school to school to school, but you don't have to do it that way. I knew several people that had jobs and
Of course.
before
industry.
this.
Yeah. I know some very successful interventional cardiologists. Shout out Dr. Kaswani, who was an engineer before he had gone into interventional cardiology. Again, just as successful. So
It's going to be hard no matter what you do, but there can be other pathways that meander a little bit first.
That's right. And I did want to harken back to something that you had said, which was really important and crucial, which was, and this is back during your training for surgery, which is do the thing that you can't not do. If you say, man, it's my raison d'etre to be a surgeon, well, then do that. If you say, I could do it.
Yeah, I've seen some people go down that pathway, and
It's not going to be fun.
even the worst, I think, is some of the people who were in medical school or even surgery residency who were just doing it to appease, more often, parents.
Yes.
Those are the ones that are the most detrimental to me. So not only did you take a spot from somebody who's very interested, you're probably going to either burn out or just like phase out. And
The investment of society that they have in you is going to be for naught.
that's the most disheartening.
That
cases.
really is. That really is.
So, yeah.
And you can be just as smart, just as sharp and hardworking, but if that's not the passion that drives you, just find that thing.
Yes.
Find that thing.
Yes.
Tell me what you do for fun. What are your hobbies?
I mentioned earlier I like reading. I've always loved reading.
Yeah.
So that's a very passive hobby, but it's something I do all the time. I've been doing it my whole life. Become a big audiobook junkie in the past many years as well. So it gives you time to do more than one thing at a time. And so I like to read. More actively, I've always loved the water, which was one of the big draws about Panama City. I grew up on the water to some extent, but it was more of a lake. And then we would
That's
drive
Louisiana
to
style.
the coast from Louisiana. We had a family camp in Grand Isle that we would always go to.
Oh, very nice.
So.
That's down deep.
Yes.
Yeah.
Oh, yeah. So beaching, swimming, fishing. Whenever I was 11, 12, learned how to scuba dive. Me and Dad learned how to scuba dive, so I've been diving since.
Okay.
Love scuba diving. Try to get more into spearfishing since being here, since a little bit more routinely love fishing.
Yes.
So spearfishing was a natural progression from there. We actually, we've been boat club members since being here, but we recently canceled the boat club because we bought our own boat.
Oh,
So
look at you. La-ti-da.
we
Okay.
are budding sailors. We have a nice new sailboat. We have our first planned big trip next week.
Where are you going?
Just Pensacola.
Pensacola.
But, yeah,
Hey, look, that's great. That's great.
It's going to be a good coastal test if we can bring 4 children there and back again.
Yeah, exactly. And everybody stays together. That's great. So,
Love cooking too.
Yeah.
Growing up in South Louisiana, you always have good food, and I always love to eat. And I realized not everywhere has good food, and so if you want to eat good food, you got to learn how to cook it to some extent.
man, South Louisiana is a special place for that.
Yes.
And I mean, you know, there's been, I had alluded to it earlier, but you know, there's some idea that New Orleans is Cajun. New Orleans is not
No.
Cajun. New Orleans is
Creole,
Creole,
I guess, yeah.
yes, and Lafayette is Cajun. Both of those are different cooking methods and kind of different cooking influences,
And
they're
then
both
they each have their
fantastic.
own version
they
of
have
the other
their
one.
subject. Oh yes, exactly. But they're fantastic food. I'm not here to say that they're healthy. I'm here to say that they are absolutely delicious, and some of that stuff will ruin you from other things.
Yes. And so, again, love cooking and seafood, and
Yeah.
so
Well, I want to probe in just because you're one of the most prolific readers that I know of, and certainly sci-fi is perhaps one of your. I don't know if
Definitely.
that's your favorite genre, but you certainly covered a lot of different territory there. What is your favorite sci-fi series?
there's a lot of books that I've read. There was one recently that's coming about. They're making a movie of. I'm looking forward to see. But Andy Weir, who wrote The Martian, he wrote Project Hail Mary. They're about to make a movie, and I just found this out, so I'm excited to see that one.
Yes. Loved that book, by the way.
Yeah.
Really fantastic. And I was actually sad that in the previews they had kind of ruined what I thought was probably the most oh my god moment of the whole thing. So anyhow,
One thing
that's
that
good.
I really like and is a series, like a long mini month spanning. You know, you're reading a dozen books or so, and you get that first book where you learn the characters, and the whole time so I really love those. Sci-fi wise, there's the Honor Harrington series, there's the Vorkosigan series. Those are two big ones that
Okay.
I really liked. If you've
All right.
not read them,
No.
they're not huge thick books, but they're great.
Yeah.
I like that character development over a series.
Yes, yeah.
Standalones can be fun too, like Project Hail Mary, but I really love the series.
You know, Andy Weir has kind of a unique scientific bent. That's kind of one of his themes, that science
He's just
will save
announced
us.
that he's writing another standalone novel that's going to incorporate AI, but
sure.
he's going to avoid, I think, some of the AI relationships. I was reading an article about it the other day. Looking forward to that one coming out.
He's good like that. But you know, we've talked before about things like the Expanse series. That's probably a middle series for you. It's a 9-book series, but it's great.
They even made the
TV show.
Yeah, the TV show. They did. On the first 6 books. So.
Yes, which was really good. But the book series was incredible.
It was great.
And then I just started the Red Rising series, which I've
that one's good too. It let me down in the end. The first trilogy is better, and there's still 1 book to come.
Okay, yeah,
but
good.
It's good the whole time through as well.
Well, I really enjoy this because whenever I start to talk about some new, hey, did you hear about the sci-fi book? You've invariably read it and read the whole series and know the lore and everything like that.
I like outside of sci-fi too. There's some other good, like the more Lord of the Rings style. Yeah. I like the
high fantasy.
I like fantasy things that aren't real because it's a good escape from everyday life and reality to some extent.
Yes.
So
like Brandon Sanderson.
Brandon Sanderson's great. I've read all the Mistborn trilogies, and those are good. One that I don't know how I fell into this. There's a new genre. I'm trying to think of how it's like lit RPG or literature role-playing games. Have you heard of this?
No, I haven't. This is interesting.
I was speaking of
nerdy
AI.
like me. Yes.
One thing that you can do with AI, if you have no idea what book you want to read, you can get into one of these AI programs like, I like The Expanse, and I like this book, and I like this book. I like this author style. I'm looking for something that has whatever you want to type in. Give me some reading recommendations. And that's what I did, and it spits out, garbage in, garbage out, but it spits out whatever you some recommendations. That's how I got on this lit RPG. I think I'm saying that right. Category.
Okay. Yeah.
And there was one of the books is called Dungeon Crawler Carl. The other one is
I think you mentioned this one before. Yes, and I heard it's very funny
it's funny. It's hysterical. Yeah. It's a complete. It's basically like a video game in real life where these people are living their life, and for whatever reason, their life is turned into a video game. And there's power-ups and special.
It's kind of like Ready Player One in that it's like pop culture mixed in with
a lot of
some
pop culture.
Yeah, which
there's one that I'm reading right now because I finished the current Dungeon Crawler Carl series with 7 books so far. They got a few more pending. He Who Fights Monsters. Okay. So it's just ridiculous, non-real stuff. That's again that fantasy genre. That's a good, fun escape from life.
Now, is this whenever you have a brief moment that you're reading, or I hear you do an Audible?
One of the things that I put in the AI thing was good audiobook production quality. Because over the past many years, whenever Amazon got into this with Audible and whatnot, there's some really good production quality audiobooks out there. Sound effects, different voices, and so that's one thing that I'm looking for now too. Is I don't want somebody to just read me a book. I want to be captivated by it and immersed. And so there's a lot of good ones out there too.
Yeah, I hear the Harry Potter series has gotten rave reviews that they've just redone it, and it's supposedly very highly produced. Same thing with Lord of the Rings. I think has some good voice acting.
So I'll put it on whenever I'm doing whatever, running, working out, doing task, cutting grass, whatever it may be. I'll just put my headphones on and.
Well, whenever I come to my next series, I'm going to come to you and just get the preview of whether or not it's worthwhile. So
I could recommend several good long series.
87 book series. No, it's kind of tough to chew through sometimes. Yeah. So, all right. You ready for some rapid fire questions?
I don't know. Lightning round? Is this?
This is what's going to happen here. Boy. It's lightning-ish round. Okay, you can expound upon it if you want. Okay.
Fair enough.
All right. Who is the smartest person in history?
Smartest person in history.
Yes.
Are we talking about just like intelligence smartest?
You can take it wherever you want to here. This is no rules. I'm not trying to cramp you into a box.
Smartest person in history. I mean, honestly, I don't know. I don't even know where to go with that. Like cliche, I just want to say Albert Einstein because that was the first thing that popped in my head. But
it's not a wrong answer.
Yeah, I don't know. I'd have to marinate on that one. But just off the top of my head, that's modern day. Which a lot of political stuff aside, one of the people that I think is incredibly smart is just Elon Musk with all the stuff he's doing. It's just crazy.
Yeah, I mean,
And it's not just him, but it's...
No, I agree. He's got this entrepreneurial vision about things, and I think he speaks towards this idea of purpose, of getting your
A goal,
purpose in
a
mind.
unified goal.
His goal, he wants to make us a multiplanetary species. How do we do that? And then he starts, and then he retrospects to the things that he has to do. Well, we'd have to build a company. We'd have to keep people alive long enough. Just all these other things kind of fall from that. But I think there's a really important point there, which is that find your purpose, find your why first, and many other things will start to fall from that. But he's also got some high intelligence and some high capability, high agency in order to get this stuff done.
SpaceX, Tesla, the Boring Company,
XAI.
XAI.
And he's building Colossus now, largest. I mean, all these things are really, it would be an incredible feat for any one person. So to have all of them together is, and maybe, with self-driving cars, we again make motor vehicle collisions.
It's definitely going to go down. They've already, I think they're 8 to 10 times safer based on the data, which is
I've
wild.
heard of some insurance companies that will give you a discount for using the
Tesla actually has their own insurance, but it's not approved in every state, whatever legal issues there are. But yeah, they give you benefits based on your driving history.
Yes, and you do drive a Tesla. So,
I do. I bought it for the smart self-driving, and our other vehicle is a Yukon Denali, and my wife preferentially takes the Tesla because it's just so much more fun and easy to drive because it's driving you, and it's wild. The electric part of it turned out to be a boon as well because it's just easy. It charges in my garage when I'm not using it.
That's right. That's right. A lot of creature comforts in that car too. So really cool.
Highly recommended. I don't see us not having a Tesla or comparable
vehicle from here on out.
Yeah.
My wife and I said with our last cars that we got, it's probably the last ones that are going to be non-electric. So we may as well enjoy it while we can.
It's amazed how much I like it.
So apropos to that, if we can live to be 1,000, should we do it?
Yes.
At night, do you want it too cold or too hot?
Kind of not either, but on the edge of too cold as opposed to too hot.
That's the right answer. I just want you to know. Okay, so objectively, if you could go right now back to when you were starting medical school, what's one thing you would tell yourself?
If you would have said undergrad, I would have said choose a different major. But,
med school is where I focused here.
From medical school onwards, I don't know that I would change from medical school. I'd just keep going.
Yeah, great.
Put forth the work.
What is one current medical treatment or therapy that we do that we are going to shudder at that we did 15 years from now?
I think there's several things that we are going to look back and say it was a little barbaric. Not because it was wrong at the time. It was right at the time.
Best that
it was
we could
all
do.
we
Sure.
knew.
Sure.
But it's one of the things that's interesting in surgery and trauma. We literally have to hurt people to help them.
Yes.
And if you think about some of these, I think vascular surgery is one of the big areas, especially from your standpoint, cardiology. People used to get their chest cracked open or big open aneurysm repairs. We can do things so much nicer endovascularly with these small little cuts or incisions. So there's going to be a lot. I think we're going to get a lot more minimal from a general surgery standpoint. We used to do big open incisions on the belly, and now like Chris is a wizard with the robot. There's some things that are. I just think some of the harshness and barbaricness of surgery is going to go away as more. I don't think it'll ever truly go away, but it's going to change in ways that we haven't been able to foresee. Yeah,
it's been an interesting thing too, because as we're getting better at minimally invasive, as we're getting better percutaneous stenting versus having to do open repair and bypass, the question is, will your surgeons get less practiced at that? I could spend a whole another podcast just on talking on that subject. But one of the things too that you made me think of, we were talking about AI, as the evolution of oncological therapy came about. That's the famous Halstedian model, like more surgery is better. More breast cancer is a surgical disease.
Breast cancer is a surgical disease.
You need to remove more. Yeah.
And we still do breast surgery, but we've completely
totally
swung the
revamped.
pendulum.
Yeah.
As AI and some of these, we again shotgun chemotherapy and radiation. As we're getting better now, there's these biologics that have come about. I think AI is going to really progress. There's going to be a point where some cancers, you take a pill or get an injection, and it's going to evaporate the cancer, for lack of a better word. And so some of these former surgeries that we did are going to disappear.
I totally agree. Now that we're getting oncotypes, the actual genotypic expression of
Specific
the cancer,
to that individual
specific
patient.
to that individual cancer, bespoke to that cancer, you can now get much more bespoke treatment. So I think that's a really...
Some of that I think is going to just go to the wayside. I mean, one of the most horrific surgeries a general surgeon or traditionally can do, a Whipple. The pancreas. I mean, whenever they melt that pancreas tumor away, and you don't have to do that anymore.
It's going to be so great. And just for the lay audience, a Whipple procedure is where you have to remove a tumor mass from the head of the pancreas. And the pancreas is a retroperitoneal organ, which means it's kind of deep into our body, really posterior, close to the spine. Very difficult place to get to. And in order to find it and remove it, you have to remove a lot of other stuff too. You're going to be looking at a 8-hour-long procedure. And then
once you get it removed, you got to put Humpty Dumpty back together again. And it is not a physiologically ideal reconstruction.
And so you're changing around the visceral organs and how they're going to be flowing. And so it's a monster procedure. If we could get to where we never had to do another Whipple because we were taking care of pancreatic adenocarcinoma better, what a boon to humanity. So, all right. Well,
that wasn't exactly lightning, but
No. We can expound upon this. Now we talked about your book series. What book are you reading right now?
I'm on the He Who Fights with Monsters series.
Okay.
That's my audiobook that I'm usually got a few going at a time.
Yeah, some hardcover book, an iPad book or something.
Yes, and I have my Kindle book, and I cannot remember the name of it offhand. But I'm reading a book on Kindle, and then I've got an assorted set of magazines that Cruising World is what I'm reading right now.
Okay, all right, good. All right, and then last thing here, what's the best song of all time?
Best song of all time? I love music. I'm always got music on. It's one of the things that irks my wife sometimes is I don't listen to it. I just like the background noise. And I don't know. Even in the operating room, it's like, what do you want to put on? I was like, just put something on. It's like the absence of noise is more disturbing to me than unless it's just
more conspicuous,
completely awful. I don't know. Maybe the voices in my head start talking when it's too much silence.
Don't let them do it.
I'm not sure. So I can't. And I listen to a whole bunch of different genres of music. So me just like picking one song out, I'm gonna have
this lightning round is hard here.
Hard time.
Okay,
I don't know.
Fair enough. I'll let you off the hook and say, thank you so much, Jamie O'Neill, for being here with us on the podcast. Thank you for being a member of our community. Thank you for being on the board here at the Emerald Coast Medical Association, and thank you for saving all the lives that you do. It's really it's wonderful to know that my family, God forbid, should they need you, that you'll come a running. So thank you so much for being here. And thank you to the audience for helping us make medicine better together.
Glad to be here. Thanks, Donnie. If I had to put you on the spot, what's your number one song?
It's called Mission Control, and it is from No Knife. And
I thought you would have been a Taylor Swift fan.
Well, that's second best. So it's... All right. Thank you.
Yep.